Good morning, and I welcome you all. We are on the free paper trauma 2 semifinals. So I just like to take the attendance first. I just want you to raise your hand if present. The first one is Dr. Arun Dasgupta. Okay. Dr. Deepak Tiwari. Excuse me, can I get a pen? Pen. Okay. Prerna A. Shetty. Okay. Neerja Verma. Not there. Shubham, not there. Brishti Majumdar, yeah, they can you come forward, please? Ashish Ghosh, we are there. Priyanka Mohanty, not there. Apurv, not there. And of course, Ashish Markan is there. Right. So, are you ready with your presentations? The first speaker would be Dr. Deepak Tiwari, not there. Dr. Arun Dasgupta, yeah. So come over, please. So you'll be speaking on a study on vision-related quality of life in patients with traumatic retinal detachment. They don't have the program, nothing. ये तो यही स्क्रिप्ट आई है.
Don't even know how do we assess.
We don't have anything. We are supposed to judge, no? Can you just hold on, please? They haven't given us anything. But वो organizer से कोई आए नहीं है ना. Just ask them if they got an envelope. We have the chairman over here, Dr. Parihar, a very senior person in India.
Sorry, sir.
Good morning, sir.
बहुत time लग गया.
अरे नहीं sir, यहाँ ढूंढने में time लगता है. Only problem is they haven't given us a program. And judge कैसे करें? बस कोई sheet ही नहीं है, वो अक्षय नायर is from Bombay. हाँ, I just हाँ यही कर सकते हैं. Yes. Akshay, do you have a pen? Pen है ना? Okay. No, that's fine. We'll just
Start it.
we'll start. Yeah. Okay. So, Dr. Arun Dasgupta, you please carry on. You start with your talk.
Good morning. I'm here to present a study on vision-related quality of life in patients with traumatic retinal detachment. Now, we all know what retinal detachment is and what the types are. Hogwood and co-workers proposed to define traumatic retinal detachments as rhegmatogenous retinal detachments caused by open or closed injuries due to direct or indirect mechanisms. Now, the various causes of TRD, traumatic RD, have been found to be those involving trauma in construction work, in manufacturing industries, sport-related industries, explosive injuries, accidents, and those caused by foreign bodies. And while the main treatment options remain scleral buckling and vitrectomy, visual outcome and vision-related quality of life are still not the same. The IND-VFQ33 questionnaire is a culturally valid questionnaire for the same purpose, which has 3 domains: the general function, psychosocial function, and visual function. The objectives of this study has been to evaluate the impact of retinal detachment in daily life activity of the patients and assess the preoperative and postoperative visual acuity and visual function in the same patients. The study was a prospective observational longitudinal study conducted at RIO Kolkata from March 23 to February 24 among 60 patients with unilateral retinal detachment, and these patients were all pseudophokic or had clear lens with no media opacities. Those who were uncooperative, lost to follow-up, and had miscellaneous ocular and systemic disabilities were excluded. The candidates with traumatic retinal detachment who were planned for OT were assessed and their vision was recorded as per this chart. And after that, the IND-VFQ questionnaire was administered along with the socio-demographic variables. After the surgery was done, these candidates were re-evaluated on their visual acuity and visual function, and they were follow-up up to 6 months. The pre- and post-surgical scores for the scale were recorded. As far as scaling in this, scoring in this scale is concerned, a score of 1 means no difficulty at all, and a score of 4 means a lot of difficulty. And this is how data was collected. We come to the results of the study. Most of the persons included in the study were males and were more than 50 years age with a visual acuity of less than 1/60. As far as the time of presentation is concerned, more than 6 months maximum presented after trauma. And among blunt and penetrating trauma, the most important cause has been trauma due to projectile objects. As far as the retinal findings during presentation were concerned, most of them presented with a large break or hole noted at the superior temporal quadrant, and some also showed grade C and D PVR changes, subretinal tractions, and other such features. Most of them were planned for vitrectomy with SRF drainage and tamponade, while around 35% had blind-assisted vitrectomy done. Some suffered from redetachment within a period of 6 months, while silicone oil-induced IOP rise and epiretinal membranes were also seen in high numbers. Now coming to the employment status and the economic part of this study, 8 subjects were already unemployed when they presented to us, and many had to either change their profession or got unemployed in the due course of 6 months even after surgery was done. As far as the visual function is related, as far as the general function, most of the patients had difficulty in finding their way in new places, going to social functions, recognizing people from a distance, searching for things at home, and seeing things coming out when they were out of sunlight. And this improved significantly after the surgery. After the eye surgery, most could enjoy social functions more than before and had better vision in sunlight while seeing vehicles. The correlation between the preoperative visual acuity in the OT and non-OT eye with the IND VFQ score suggested that the correlation is stronger for the non-OT eye than the OT eye with the score, which suggests that the better eye is of more significance as far as vision-related quality of life is concerned. This also improved significantly after study. Coming to the age-wise distribution, even though general function was better after surgery among the 25 to 50 years age group, the psychosocial satisfaction was better among those of more than 50 years age. Here are a few cases, and coming to my discussion, it has been seen that there is significant impairment, and this increases with higher age and female gender, and the mental health is more affected among the 25 to 50 years of age group. To conclude, I would like to say that more such studies should be undertaken, and care of the better eye is of utmost importance in cases of traumatic retinal detachment. Urgent referrals and screening of the at-risk population with special emphasis on the psychosocial well-being of the patients helps in dealing with such cases. Here are my acknowledgements and here are my references.
Thank you. You mentioned about the fact that to have a detachment, you need to have some kind of penetrating object going into the eye.
Sir,
so can the blunt traumas also cause RDs?
Yes, sir. I have shown in this slide.
No, that's fine. That's why I'm just asking your question.
Yes, sir. They have been found to see other than trauma with any projectile objects may cause RDs. It has been seen in the study, and they are more in number.
Blunt traumas can cause detachments, which is quite oftenly seen, a blunt trauma. So basically a trauma causing to the globe can cause a detachment, whether it's projectile or not projectile.
And these cases present late because they often don't
so you have to keep this thing in your mind very, very clearly.
Yes.
So that's it. Right, thank you. So we have the next speaker now. You'll get 5 minutes, so the timing is being done over there. We don't have Dr. Deepak, Dr. Prerna Shetty is there. Can you please come over here? And you're speaking on analysis of traumatic wound dehiscence following keratoplasty, factors affecting visual outcomes. Yes, sir. Absolutely.
Okay, good morning all. So I'll be talking on analysis of traumatic wound dehiscence following keratoplasty, which will also include factors affecting the visual outcomes post that. There are no financial disclosures. So I would like to start with the problem during COVID-19, that the policy of social distancing had crippled the ability of hospitals to deal with large number of patients, and the delay in reaching the hospitals due to this lockdown led to progression of the disease, further intensifying the difficulties. When we come to the ocular trauma per se, any globe is susceptible to rupture, and post-operatively, the corneal scars are unlikely to regain the original pre-injury strength and remain vulnerable to spontaneous and traumatic dehiscence. Grafts with larger extent of dehiscence has a higher likelihood of posterior segment damage and a poor final visual outcome. And the avascular nature of corneal scars is what prevents effective wound healing and remodeling, creating continued weakness at the graft-host junction, and even long after the wound appears well healed clinically. So the wound dehiscence may be spontaneous or traumatic. The incidence of wound dehiscence after corneal transplantations ranges from 0.6 to 5.8% in the literature, and following trauma, it has been reported to be 1.28 to 2.53%. The highest risk period for graft rupture is in the first post-operative month. The posterior damage segment has been reported to be associated with poor visual outcome, and the extent of visual loss could have been reduced if protective eyewear had been in place. With this background, the study which we did was to evaluate the factors and outcomes of traumatic graft rupture at a tertiary eye care center in South India. It was a retrospective study which was 3 years, and the informed consent was taken and the data collected via the EMR. A minimum 1-year follow-up was included, and the cases operated elsewhere before presentation and other causes of resurgery were excluded. Appropriate statistical tests were used, and a multivariate regression analysis was performed to evaluate the factors associated with visual outcomes, and a p-value of less than 0.05 was considered statistically significant. So moving on to the results, we had 20 patients with 65% being male and 35% female, with an average age of 43.1 plus or minus 18.12 years, with 13 patients coming from the urban areas, while 7 were from the rural localities. The average time between the penetrating keratoplasty and the trauma was noted to be 4 to 6.4 years. When we looked at the pre-operative factors, we looked at the visual acuity, the time between the penetrating trauma and the PK and the trauma, as well as the resurgery in months, the primary cause of the penetrating keratoplasty, and the lens status. While in the intraoperative factors, we included the duration between the trauma and the surgery, any presence of intraocular foreign body removal, use of intracameral antibiotic, any other complications, and need for any second surgery in the first week. So when we compared the initial and the final visual acuity, we saw that the initial vision in logMAR units improved from 2.04 plus or minus 0.46 to 1.86 plus or minus 0.55. So when we did a multivariate analysis of pre-operative and intraoperative factors associated with the final visual outcome, out of all the factors, the duration between the trauma and the surgery was statistically significant. So these are some clinical pictures of the pre and the post resuturing after the wound dehiscence. And when we also went through the literature, we finally concluded that the effect of duration between the trauma and the surgery it affected the outcomes, which was statistically significant. Posterior segment damage was associated with poor visual outcome, and wearing protective goggles was necessary to avoid wound dehiscence. The limitation of this study was it was a retrospective design, and a larger sample size would have improved the statistical power. And to conclude, the best corrected visual acuity at presentation, duration between the PK and the trauma, wound dehiscence site, iris prolapse, vitreous prolapse, and the duration between trauma and surgery and the follow-up procedure can influence the outcome. Though the graft in particularly vulnerable to dehiscence within the initial post-operative 1 month, it is important to note that this complication can arise at any stage of the recovery process. The time lag between the trauma and the surgery will negatively impact the final visual outcome, which was statistically significant in our study subset. So, thank you.
Thank you. It's an important topic what you have presented. It's a very natural thing that you got to be careful about the wound dehiscence, especially after the trauma when you're doing a PK. So can you just tell me what kind of depth are you taking the sutures when you take the corneal suture? What kind of depth are you going up to?
So when in a PK we take 90% depth, just
90% depth. And what kind of sutures are you using?
use 10-0 nylon sutures for that.
And do you have any idea that all the sutures needs to be radial to each other, parallel to each other, and radial, in order to decrease the astigmatism,
It
in
has to
order to not to have so much of wound dehiscence, which probably I didn't see it. So it's important that your sutures should be, of course, 90%. They should be parallel to each other as far as possible in a trauma case, and they should be radial in
radial to
order to
the
decrease the astigmatism. Akshay, anything? Right, thank you.
thank you.
We have the next speaker now, Neerja. You'll be speaking on comparison of visual outcomes of traumatic optic neuropathy, patient with and without intervention.
Shall I start?
Yeah, please carry on.
Okay. Good morning. I'm Dr. Neeraja Verma, DNB resident from Netradama Super Specialty Eye Hospital. So I'll be presenting regarding comparison of visual outcomes of patients with traumatic optic neuropathy with and without intervention. So TON is the most common cause of visual loss after blunt trauma to the head, and management of TON is still variable and no consensus has been made regarding any set guidelines as how to treat. So currently accepted management include observation, oral IV corticosteroids, surgery, or just a combination of both. So the purpose of my study was to compare the visual outcomes in patients with TON who receive different treatment modalities and to analyze the predictors of visual outcomes, the prognostic factors good and bad. So it's a retrospective study, and all patients who are diagnosed with TON at first presentation were included, and those who have completed the treatment with final BCVA, that is after 6 weeks. So the study period was 5 years, and all patients within this 5-year period was taken, and the demographic details, time of presentation, treatment given, visual acuity before and after treatment were taken. So out of the total 96 patients in 5 years, only 46 patients completed the treatment and the final BCVA recordings were taken. So all those who were fit for IVMP were given all the 3 doses of 1 gram per day, followed by a short course of oral steroids. And those not fit for IVMP were just given the oral steroids. So out of the total sample of 46 patients, majority 29 were given just observation, while 7 were given IVMP and 10 were given oral steroids. So the results were that 37% of patients showed improvement in visual acuity. And out of the people who were given IVMP, 100% were improved by 2 lines or more. And see, in IVMP, 2 lines or more were improved in all patients, all 7. While oral steroids, most showed no improvement, while about 30% improved by 1 line and around the same 30% improved by 2 lines or more. While nil intervention, majority more than 80% did not improve, and very few patients, we had 2 patients who improved by 6 lines. So the conclusion was that people who were given IVMP invariably showed good visual improvement as compared to oral steroids and nil intervention, of course. And PL negative is a poor prognostic factor for visual outcomes. And we had also analyzed the good and bad prognostic factors. So early presentation, early initiation of treatment, completion of treatment, and good visual acuity at the time of presentation were good prognostic factors. So the limitations were that it was a retrospective study, there was no randomization, and the lacunae in data in view of retrospective data collection. A lot of the timings were not recorded in the patients, the duration of trauma, how long back the trauma happened was not documented. And the variable sample size in the treatment group is because we had included the treatment from different specialties. The doctors, how they treated were different, and based on the timing, a lot of people were not able to intervene. So that is my study. Thank you.
So I had a question. You mentioned that duration between the trauma to presentation was not calculated. Any prior treatment before presentation, was that included? Because a lot of times traumatic optic neuropathy has received steroids somewhere else and come,
Yes.
and then they again receive steroids. So, was that documented?
No, sir. It was a retrospective study. If there were any documented treatment given, we had excluded them.
And any mean presenting vision? You mentioned in the conclusion that poor presenting vision or
Yeah,
poor was associated with, I mean, worse outcomes. But how many of them were PL negative? Because I think in the, if you probably list the presenting vision in the observation group, probably a
it
high
was-
percentage of them would have been
Yes,
no
sir,
PL.
yes, sir.
So unless you show that information, it masks a lot of things. Because here you would see that, you would say that steroids have to be given in every case, but ONTT and CRASH both have shown that megadose steroids actually cause more harm than benefit. So.
Yes, yes.
And at the same time, for oral steroid patients, compliance also. So you never
Yes,
know
they're
how
actually
much
taking
they have
it.
completed or not.
Yes. Sir. Thank you.
Thank you. Can we have the next speaker, Dr. Shubham? That's right. You'll be speaking on seeing through the bleed, role of FAF imaging in the management of traumatic submacular hemorrhage.
Right. So, good morning, everyone. I'm talking about role of fundus autofluorescence imaging in the management of SMH. So, these are the contents that I'll be covering. So, just to give a brief introduction, to define submacular hemorrhage is a collection of blood due to any etiology below the neurosensory retina. And as of now, there's no gold standard treatment for each cause or each presentation of a submacular hemorrhage. To talk about goals of treating a submacular hemorrhage, we aim to evacuate the blood from beneath the fovea, and we try to prevent as much damage to prevent damage to the photoreceptors as much as possible. So the current management options that we have include intraocular gas tamponade, a tissue plasminogen activator, anti-VEGF injection, or a pars plana vitrectomy. So coming to my study, the aim of the study was to evaluate baseline characteristics of fundus autofluorescence in patients with submacular hemorrhage. It was a retrospective study where we recruited all treatment-naive fovea involving submacular hemorrhage patients in which the hemorrhage was more than 2 disc diameters. It involved all etiologies. And the only thing we excluded were pre-existing retinal lesions that were not contributing to the submacular hemorrhage, such as diabetic retinopathy, any retinal breaks, etc. So we recorded the patient demographics, we took a detailed history, we recorded the best corrected visual acuity at presentation and at follow-ups, and we acquired good quality color fundus photograph with an Optos, an SD OCT with Heidelberg, and blue wavelength fundus autofluorescence images with Heidelberg as well. And then we recorded the treatment received by each of the patients, and we recorded the follow-up details. So coming to imaging, on a color fundus photograph, we recorded the finding as the color of SMH, whether it was red or yellow, and any other relevant clinical findings. On OCT, we recorded the reflectivity of the submacular hemorrhage and the presence of backshadowing and the presence of any choroidal neovascular membranes or any rupture at fovea. On the fundus autofluorescence, we recorded whether there was a hypo or hyperautofluorescence. Then we recorded the treatment received by each of the patients, where it involved either observation, intravitreal gas tamponade, intravitreal tissue plasminogen activator, anti-VEGF injection, or pars plana vitrectomy. So treatment success was defined as reduction, displacement, or elimination of hemorrhage from beneath the fovea, evaluated during the follow-up visits within 3 months after presentation, as observed on a color fundus photograph and confirmed by OCT and FAF. So to look at the results, out of a total of 80 patients that presented to us, 47% of them had a subretinal hemorrhage that did not involve the fovea. For 29% did not have good quality images. So out of the 24%, it involved a sample size of 19 patients. Out of those 19, 13 were male, 6 were female. And 11 of those submacular hemorrhages was caused by neovascular AMD, 7 by trauma, and 1 by myopic CNVM. Now, when we looked at the characteristics of SMH and compared them to the outcome of SMH as defined by our treatment outcome, the color of heme, where it was red or yellow, did not really affect the outcome of SMH. Reflectivity as well did not affect. Only the autofluorescence of heme showed a positive correlation with the outcome. None of the treatment outcomes also showed any positive correlation with the outcome of submacular hemorrhage. So to look briefly at the composition of submacular hemorrhage, a fresh submacular hemorrhage would look red on color fundus photo, would have a heterogeneous hyper and hypoautoreflectivity on OCT, and would have hypoautofluorescence, whereas an older blood would be yellow would be homogeneously hyperreflective and would have hyper autofluorescence. So pneumatic displacement is usually used to make the SMH fresh, make the SMH mobile, and is used when the SMH is mobile. TPA is used to keep the blood mobile, and a pars plana vitrectomy can be used in large SMHs. The limitation of my study was a small sample size, and the data was insufficient to compare the treatment outcomes of the different treatment modalities. Also, we use blue light autofluorescence, which can interact with macular pigments, where a green light fundus autofluorescence would have been better. So to conclude, fundus autofluorescence can potentially detect changes in the composition of extravasated blood in a submacular hemorrhage, wherein adjunct with OCT and clinical color fundus photo, it can be employed as a tool in guiding the choice of treatment modality. It can also help in prognosticating the submacular hemorrhage patients. These are my references. Thank you.
Thank you very much. I think it was well presented. All of you have well presented, and your topic was something unique. And well, of course, I myself was seeing quite a good pictures I was seeing, and which I've not seen it before. So that's it.
I mean, so you mentioned the only thing that correlated was the color. Correlated with treatment success?
Yes, sir. So that was a Spearman's correlation test where the p-value that was given was it was a moderately positive correlation. The coefficient was 0.6.
Okay. But in those with yellow color, is it?
No. So those which had a hypo autofluorescence on fundus autofluorescence.
And majority of the patients in that group were treated with which modality?
So that's what the treatment modality did not really affect the treatment outcome. So that did not really correlate with the because I mean such data can be skewed because it's a small sample size. So that's why to correlate better with the treatment modality, we need to have more samples in each group of the color as well.
Okay.
Yes.
But do you think that your treatment modality can change?
100%. Yes, sir.
In what way?
So the presentation, whether there's a fresh blood or an old blood, that would, I mean, clinically it feels like that should be the most important.
No, I'm talking in terms of your presentation regarding the color coding.
Right, sir.
So you can always make out the other way around also.
Yes, sir. Yes, sir. So
whether it's a fresh bleed or a
right.
old bleed.
Right. So in case of a fresh bleed where we would do a intraocular gas tamponade primarily, it would yield better results in a fresh blood. So the color then would correlate with the treatment outcome, with the success of SMH management, only if the correct management has been employed.
Okay. Thank you.
Thank you, sir.
Again, the limitation is color limitation.
Right. Do we have Brishti Majumdar? Yeah. So you'll be speaking on comparison of outcomes of single versus multiple surgeries in open globes injuries.
Good morning to all. I will be presenting my paper on comparison of outcomes in single versus multiple surgeries in cases of open globe injuries. Open globe injuries or OGIs are a cause of sudden vision loss, especially among the working age group. And the first treatment is always a primary repair to preserve globe integrity. However, further surgeries may be required for visual rehabilitation. And there is not much literature comparing the outcomes of single versus multiple surgeries in cases of OGIs. The aim of this study was to compare the functional outcomes of single versus multiple surgeries in open globe injuries. It was a retrospective observational study done from January 2018 to July 2024. 102 cases of OGIs undergoing single or multiple surgeries at our institute were included. Cases with less than 3 months of follow-up or undergoing any of the surgeries elsewhere were excluded. Demographic details, number and type of primary repair and additional surgeries, best corrected logMAR visual acuity at presentation, after first surgery and at final visit were noted. Cases were divided into two groups with 51 cases in each. Group 1 for primary repair only, that is one surgery, and Group 2 for more than one surgery. Functional outcomes of both groups were compared. The mean age of this study was 24.06 years, mean duration of presentation 54.9 hours, mean initial logMAR best corrected visual acuity 2.81, and mean final visual acuity 1.75. The mean follow-up duration was 12.38 months, and there were more males in this study. The figure shows that the most common type of primary repair done was corneal tear repair. Comparing groups 1 and 2, we can see there was significant improvement in visual acuity in both groups, but there was greater improvement seen for the group 2, that is the multiple surgery group. However, the p-value comparing the final visual acuities of both groups in this study was not statistically significant. In group 1, the most common surgery done was primary repair only. Few cases included procedures like lens aspiration, vitrectomy, and intraocular foreign body removal. In group 2, majority of cases underwent 2 surgeries and 6 cases underwent 3 surgeries. The parameters noted were the best corrected visual acuity at presentation, after first surgery, and at final visit, and the p-value comparing the visual acuity between these groups was significant for all, as seen. But the largest effect size was seen when comparing the initial versus the final visual acuity. In group 2, again, we divided the cases which involved procedures in the anterior segment only and procedures in the posterior segment. In the anterior segment, the most common surgery done was cataract surgery or lens aspiration with or without IOL implantation. And for posterior segment, it was retinal detachment surgery with or without lensectomy. For the 6 cases that underwent a third surgery, the second surgery involved various procedures like anterior chamber wash, vitreous lavage, and retinal detachment surgery. And retinal detachment was the most common indication for the third surgery. This table summarizes the outcomes in the study. We can see that the p-value comparing the mean initial visual acuity and final visual acuity was significant for all groups, namely the single surgery group and the multiple surgery group 2, and also the individual subgroups under group 2. This is a graphical representation showing there was greater visual improvement in group 2. So the final visual acuity was better for group 2, that is the multiple surgery group, than the single surgery group 1, although the difference was not statistically significant. And in group 2, although the p-value comparing the visual acuities at presentation, after the first surgery, and at final visit was significant, the largest effect size was seen when we compared the initial versus the final visual acuities. Similar studies done in the past include that of Sathers et al., who studied OGI cases undergoing primary repair with 2 additional surgeries. They noted greatest gains after the first and second surgery. Gomez et al. Had studied the ocular trauma score features in open globe injury cases, and they noted better improvement in visual acuity after standardization of anterior segment procedures. Studies have also noted better anatomical and functional outcomes after intervention of posterior segment pathologies in cases of open globe injuries. Hence, the popular belief that exists among surgeons and patients that vision may not improve after the first surgery, that is the primary repair, may not be so, as shown by our study. To conclude, the need for multiple surgeries in cases of open globe injuries and the knowledge of their outcomes must be borne in mind when explaining the course of the disease and prognosis to patients and their kin. Thank you.
Very good paper, doctor. And you had all adult patients in that?
Ma'am, the mean age was 24.06, so we included cases ranging from 10 years to 70 years.
Because nowadays Pediatric Ocular Trauma Society's trauma score is different. The founder of Pediatric Ocular Trauma score is there.
Yes,
so
ma'am.
at least it's a total different. Nowadays toddler ocular trauma score also has come. So you don't know what the vision is if you are taking your patient below 10 years. So
Yes,
you
ma'am.
have to take VOTS.
Yes, ma'am. Yes, ma'am.
I think it's important for all of you to remember, and sir is here, he is retired as a chief of Army Hospital in Delhi. He was there for 14 years and he's seen numerous injuries. Basically the globe injuries, what is important for you to remember is that as she presented, if required in 2 stages, should be done. Don't try to prove to yourself that I've done it in 1 stage. You need to prove to the patient. That is more important. There's a very debate going on all over the world on the forum is regarding the cataract. If you develop a traumatic cataract, people say, oh, you can do it in the first stage. Every case is different. It depends if you can manage to remove the cataract or probably just remove the fluffy matter lying in the anterior chamber and do it in the secondary stage after the inflammation settles down. So that is important that do it stage-wise. But at the same time, you cannot wait for too long. Yes, majority of the cases will require multiple. And I think it's important for the posterior segment that you evaluate the posterior segment at a later stage because it's a open globe. Don't try to go for an ultrasound, especially the B scan or the UBM or any kind of intraocular foreign body if it's an open globe. Don't try to go for a CT scan or a MRI. More important is to repair the wound, try to maintain the anatomy of the globe. I'm just talking about the very basics. If you stick to the basics, you can do well. Regarding the orbit, of course, Dr. Akshay is a master of that. He can specify maybe later on or right now.
I just had a couple of questions regarding this. So the only thing that you all compared was the outcomes of single surgery versus multiple surgery.
Yes, sir.
Did the OTS, the ocular trauma score, have any effect on whether the patient needed a single surgery versus multiple surgery? Or
Sir, actually, we did not do
So
that as part of the study.
that is something that you can add, and because you have all the data, you can actually
Yes,
even
sir.
retrospectively tabulate the ocular trauma score and see if that correlates.
Yes, sir.
Because in open globe injuries now, that is the first thing, that OTS has already been validated to with the final vision.
Yes,
So a poorer OTS or a low OTS has implications in terms of the final visual acuity and prognosis. So you could see if multiple surgeries changes that or not, or does the OTS initially still hold valid for the final visual outcome. Also, did duration from between the initial trauma to presentation have any effect on whether they needed single surgery or multiple surgeries?
Sir, though we did not include this, but it did not have a significant correlation.
Thanks.
Thank you, sir.
Can we have the next speaker? Dr. Ashish Ghosh is here. Yes, please. He'll be speaking on outcomes of repairing open globe injury combined with or without pupilloplasty.
So good morning, everybody.
Yeah. Thank you.
Good morning, everybody. Today I am going to present the outcome of open globe injury repair combined with or without pupilloplasty. I am Dr. Ashish Ghosh from Shri Ram Netralaya, Pune. Open globe injury is a significant cause of permanent visual impairment and blindness worldwide. It is associated with
This Ashish, I know that. And this Ashish, I know his name.
It is associated with significant morbidity and loss of productivity. The cornea is the major refracting surface of the eye. Minor changes in its contour result in significant visual problems. Aim is to describe the characteristics and correlations of open globe injury with sharp or blunt objects and outcomes following the surgical open globe repair for maximum visual rehabilitation with pupil reconstruction. It is a retrospective study done in the tertiary eye care centers in Pune. 15 patients included in this patient. 2020 to 24, this time period we have done this case series, and age group is 4 to 40 years included. Open globe injuries, the following signs: corneal and scleral tear, iris prolapse, distorted pupil, hyphema, and traumatic cataract. PCR was included in this study, and patient is having no PL, absolute eye, retinal surgery patients are excluded from this study. So we have done all the tests and that posted for surgery. These are the corneal tear repair, scleral tear, and conjunctival tear done. And basic instrument we used for pupilloplasty is MST forceps scissor and these sutures. The technique used single pass 4-throw pinhole pupilloplasty. So the procedure I will explain a little bit. This is a trauma of open globe injury, and in this surgery, first I have excised the iris uveal tissue, then corneal tear repair done. After that, I have seen that it is a distorted pupil with traumatic cataract. The picture is this, and then after 30 days, I just allow the heal the wound, and then the surgery is done for cataract surgery and implanted lens, foldable lens, and in the same sitting, the second sitting, I've done the pupilloplasty. Single pass 4-throw pupilloplasty is done with the propylene suture. This is another case. This is a 13 mm copper wire trauma. uh, is gone to the eyes and it is removed. This is a pre and post-op cases. This is a 5-year-old boy, tiles injury, iris prolapse. I have done pupiloplasty with corneal tear repair. This is another case. So results, the 3 patients underwent the second surgery after 3 to 4 weeks, and intraocular foreign body found in 1 patient, scleral patch graft done in 1 patient. The result is out of 15, 12 patients were male, around 80%, and age group 0 to 20 years age group was more. It is 10 out of 15 patients. The pencil, sharp tiles, stone, knife injuries, steel wear, and hard hand injury, fist injury is there. And the important findings, we have seen corneal tear, shallow AC, iris prolapse, distorted pupil, and hyphema. Out of 15, 10 patients pupiloplasty we have done, around 67% patients undergone pupiloplasty. Vision improved after 1 month or after 2 months. Vision improved more than 612. It is 67% patients improved more than 612. The zone 1, 73% patients, the trauma is included in the zone 1, and size of the wound maximum was 3 to 6 mm. The discussion, the corneal scar following perforating corneal injury causes the significant visual reduction, mainly because the direct obscuration of the rays. Pupilloplasty will give a good visual outcome if corneal scar is not there in the center. If lens injury is there, cataract surgery can be done after the second sitting. And pinhole pupiloplasty is one of the sophisticated procedure we should do in post-trauma cases to get the best good visual outcome with less astigmatism and the indications are the functional and optical indications for iris defect,
Please sum
iatrogenic.
up. Please sum up. Time is up.
And conclusions. Should I continue, sir? Yes. The conclusion is that corneovascular tear repair done in open glove injury cases is insufficient. Alone is insufficient. Adequate time must be given to corneovascular wound to heal. And cataract extraction, IOL implantation, pupiloplasty will give the best best possible outcome in cases where traumatic cataract occurs with pupil distortion. Pupiloplasty should be considered in post-trauma cases if pupil is distorted. Thank you, sir. Thank you.
Thank you very much.
So majority of, I'm sorry. So majority of your patient, you said that only single pass, 4th row.
Yeah.
So is it possible for traumatic pupillary, irregular pupils? So all the pupil cannot be the same way.
Yeah.
You cannot repair all pupil with
And
the
not
same
possible,
way.
ma'am.
It's not possible in
Yeah.
trauma.
Yeah.
So, and what was the difference when you did single pass, double pass? You said that you have not done double pass. So ultimately, you're not studying that part. Visual outcome also will affect, and corneal astigmatism will
Yes.
also affect higher order aberration will also
Yes, ma'am.
affect. for
Actually,
that.
just we gone through these cases, so I thought I have seen many presentations that pupiloplasty was not there in trauma
Yes.
cases. Sometimes we are ignoring patient is having some problem, so we thought we can.
Yes,
present.
so aim was to prevent them myopia. That was wonderful thing, but
Yeah.
pupil always in trauma, it will be a varieties of pupil.
Yes,
You
yes,
cannot have one.
Wherever possible, we can do. So that's why.
Thank you.
Thank you, madam.
We have the next speaker, Dr. Priyanka Mohanty. And Dr. Apurva is not here, no? He's absent. Dr. Apurva, you're there. And at the last, we got Dr. Ashish.
I think Dr. Deepak Tiwari.
No, he's absent. Sorry.
Good morning, everyone. I'm Dr. Priyanka Mohanty, junior resident from IMS Patna, and going to present a case series on canaliculi involving lid laceration, showing anatomical and functional outcome. There is no financial disclosure or no conflict of interest. Eyelid laceration involving the canaliculi has a prevalence of around 10 to 20% of all eyelid trauma, and the common modes of injury involve Blaujock fastener, animal bite, fall, blunt trauma, or RTA. The presentation is usually late and associated with other life-threatening situations, so the subsequent delayed repair leads to scarring and constriction of the lacrimal pathway followed by lifelong symptomatic epiphora. It's more prevalent in case of children and young adults, with males more frequently affected, and the surgery involves primary suturing along with mono or bicanalicular stent placement. Coming to the methodology, over 6 months of period, we took patients with lid laceration with the canalicular involvement operated in IMS Patna. The distal cut end was identified as a pinkish white mucosal structure, followed by the Bowman's probe was introduced to look for a hard stop through the punctum. After that, a monocanalicular stent was used and along with pericanalicular suturing. The removal was planned at 3 months post-surgery and syringing was to be performed. The functional outcome was observed as absence of epiphora, and the anatomical outcome was observed as with respect to structural integrity and patency of the nasolacrimal duct. These are few of the pre and post-op images. As you can see here, this patient had a lower lid laceration with the canalicular involvement. We put a stent, and at 3 months of post-op, we removed the stent and the NLD was patent. This is a similar case with similar outcome. This was a child who had a trauma due to blouse hook fastener while being breastfed by the mother, and the similar procedure was noted. But these children had both upper and lower canalicular involvement with edema and late presentation, so we could not locate the puncta and only primary repair was done. Coming to the observation from my case series, lower lid involvement was more common rather than upper lid, with consisting of 10 out of the 12 cases. 4 toddlers had injury due to blouse hook fastener, which is quite unique to our country. And there was male predilection with 8 out of the 12 cases, and less than 18-year group consisted of 9 patients. The presentation and subsequent repair ranged from within 24 hours to 5 days post-injury, and the edema and inflammation in late presentation produced difficulty in finding the canaliculi and subsequent stent insertion. And coming to the results, at post-op 3 months, only 3 patients were completed and the stent removal was done. There was no regurgitation of fluid from the involved canaliculi. Premature pulling was present in case of one child and another was lost to follow-up. In case of pediatric patient, the absence of epiphora with stent in situ was taken as functional outcome, as they are not cooperative for syringing under topical anesthesia, and we cannot take them under GA for multiple times. Coming to the discussion, lacrimal canaliculi lacks a tarsal substructure and displacement from the cancel tendon increases the risk of tear. The preferably repairs should be done within 48 to 72 hours, but there is no clear guideline. The methods for locating the canaliculi we can identify as an anatomical landmark by elevated tubular structure, or we can inject fluorescein or air bubble. Fiber optic light probe can be used, or we can also use pictal catheter, but it is less commonly used these days as it is traumatic to the normal canaliculi. After that, stent insertion can be done. These are few of my related works and references. I would like to conclude saying that it needs skillful surgical intervention at appropriate time if there is no other comorbidity, and stent placement can significantly improve a patient's quality of life, and meticulous tissue apposition improves the cosmesis. There should also be awareness regarding safe breastfeeding in a country like ours. Thank you.
Just a moment, excuse me. You'll have to come back.
So you said the duration from trauma ranged from within 24 hours to 5 days.
Yes, sir.
So out of the 12 patients, you showed one patient in whom it was not possible.
Yes, sir. He presented after 3 days of trauma.
Any other patient in that series, or
No, most of the patient presented within 48 hours. Sir.
within 48 hours?
Yes.
And did the patient in whom the stent was lost or the stent was pulled out, did it have any effect in the final outcome?
He had symptomatic epiphora, but the child was only of 1 year of age, so we are
Syringing
waiting
was not
on the follow-up.
Yeah, and all the patients were used only silicone tubing,
Yes, sir. Ma'am, mini monoca stent
only
was
mini
used.
monoca.
Yes,
And
ma'am.
you got any of the patient where you could not find the
There was
nasal
one
and
patient we could not find.
so what did you do in that?
Only primary suturing was done, ma'am, and the
Okay.
patient was kept on follow-up.
So for just the reference, we have got one drishti canaliculostomy intubation set,
Yes,
which
ma'am.
where you can find the cut end of the canaliculus, nasal end of the canaliculus, as well as the stent is already there with that.
Okay.
That stent you can use in 10 patients. So that's very, very effective and very easy technique when
Yes,
you
ma'am.
don't have to use air bubble and fluorescein. And I tell you, it becomes mass when you're using any
Only
fluorescein, anything.
minimum.
It doesn't work like that.
Thank you, ma'am.
Thank you.
Thank you. We'll have the next speaker, Dr. Purv. Dr. Purva, she'll be speaking on retrospective analysis of scleral tear repair for MSICS wound dehiscence. And after that, we have the last speaker, Dr. Ashish Markan. Sorry? Well, we are doing the semi-final.
It's clubbed together.
It's clubbed, so we have got the papers of yours as well. So your slides are ready? Yeah, so you're the next speaker.
Ashish, not good.
Yes. Good morning, everyone. Today I'd like to present my study on retrospective analysis. Sir, can we reset the timer, please?
Okay. Timer reset. kar do,
Good morning, everyone. I'd like to present my study on retrospective analysis of scleral tear repair for MSICS wound dehiscence. I have no financial interest in the study. As we all know that cataract surgery has evolved from ICC, ECCA, MSICS to phacoemulsification, where the wound length has decreased and the wound strength has increased over time. Manual small incision cataract surgery is still very widely performed in our country as it is machine independent, cost effective, sutureless procedure which gives good post-operative results. But the trend is now shifting towards phacoemulsification because of the new government schemes, better and affordable intraocular lenses and awareness programs. In the Indian scenario, the old age population is on the rise, that is increased to 5 to 6 times over the last 60 years, and they are highly susceptible to falls and injuries. As reported by Cloak et al., 1/3 of the open globe injuries were cataract wound ruptures. The purpose was to study the surgical wound dehiscence following MSICS and analyze the predisposing risk factors of wound rupture and visual debility. Objectives were to study the profile of the patient's reasons for trauma and visual rehabilitation. It's a retrospective observational study in which 421 open globe injuries were evaluated over 2 years and 79 patients with scleral wound dehiscence were included in the study. The patients were diagnosed on slit lamp examination, confirmed intraoperatively on microscopic examination. The patients were evaluated based on demographic, trauma details, and management and outcomes. We came up with the results that 70% of the patients were more than 60 years of age. There was no gender predilection. The traveling distance was found to be less than 100 kilometers in 67% of the patients, and which may lead to improper treatment on first presentation outside if they are living far away, and late presentation may lead to poor visual outcomes. Cataract surgery to presentation was evaluated, and we found that 20% of the patients reported to us within 6 months of cataract surgery, and 42% reported more than 4 years after cataract surgery. There are case reports saying that wound dehiscence can happen even after 20 years of cataract surgery, so stability of the wound is the main criteria. The injury to presentation was evaluated. We found that 87% of the patients reported to us within 1 week of injury. Injury being external blunt injury in 43%, cattle or animal injury in 23%, and self-injury or fall in 19%. Lens status was evaluated, and we found that IOL can be dislocated in 55. IOL was dislocated in 55%, and 16% IOL was expulsed outside. The severity of the dehiscence was categorized based on these characteristics, and we found that 75% of the patients had severe dehiscence. Posterior segment was involved in 56% of the patients, whereas 51% were left aphakic. Vitreoretinal surgery was required in 28% of the patients. Presenting vision was compared to final vision, and we found that we were able to provide good visual outcome, that is around for 30% of the patients we were able to provide better than 6/60 visual acuity, and poor visual outcome was found in around 30% again, with perception of light vision or no perception of light vision. When severity of dehiscence was correlated with age, type of injury, duration from cataract surgery, and final vision, we found that it was only significantly correlating with final vision. We found 2 cases of wound dehiscence and phacoemulsification during the period, which was because of blunt trauma with clinical features of hyphema and iris prolapse, where IOL was stable, and we were able to provide good visual outcomes for these patients. The literature was reviewed, and we found that a study by Cloak et al. Compared ECC versus phacoemulsification in 63 patients over 9 years, 63 patients of wound dehiscence over 9 years. and another study in which ECC versus phacoemulsification was compared, and they found 76 patients over 15 years in Taiwan. The limitations of our study were that the data related to the strength of the cataract wound was not available with us, which may need prospective study in the future. So I would like to conclude saying that as doctors, we should aim to provide a stable wound MSICS surgery, especially in the elderly population. And for patients, if there is any trauma, their early presentation should be emphasized on in follow-up presentations for these cases. Thank you.
I think well presented.
Thank you, sir.
Neat, clean graphics. I had a couple of questions. Did you document the other eye status? Because if the other eye
Yes,
is
sir.
actually, cataractous with advanced cataract, that can actually impact their mobility. And
Yes, sir. Actually, we evaluated, but I have not included this in this presentation. We had evaluated around 30% of the patient had brown to mature cataract in the other eye, which made them very difficult. Their day-to-day activity is very difficult. Other patient had IMCs, and some patients had PCIOL. In this study, the patients which had undergone scleral tie repairs for these patients, some patients had undergone SFIOL in the future.
Alright.
So some patients
and I forgot to catch it if you mentioned the mean follow-up period.
So mean follow-up period, we were able to follow up these patients up to 6 months.
All of them?
All of them, sir.
Okay.
Some patients 20% patients had fallout from follow-up, but other patients we were able to follow up. Some patients are still waiting for SFIL surgery, sir, so that is still to be evaluated.
Well, Dr. Akshay asked you about the fellow eye,
Yes, sir.
and you said about 30 to 35% of them had
Yes,
quite a
mature cataract and brown
advanced
cataract.
cataract. So, did you ever think of operating that eye first and then going ahead with the second eye, the traumatic eye, in
For
order to give
SFIL?
him better mobility?
So our first approach was to repair the wound. After the scleral tie repair only, if there is any vision threatening thing happening in the posterior segment like endophthalmitis or anything
No, I'm
like
not
that.
talking about endophthalmitis. I'm talking a very straight, simple question that the fellow eye has got an advanced cataract and the other eye, traumatic eye, has already been repaired
Yes,
somewhere
sir.
else. We are talking about the wound dehiscence.
Yes, sir.
So, did you think ever of doing the fellow eye, the cataract eye, first to give a better mobility?
Yes, sir. Yes, sir. And some patients were planned for the other eye cataract surgery to give them better mobility.
Beforehand?
Beforehand, as in,
Before
sir,
doing the traumatic eye.
traumatic eye, after scleral tie repair only we were taking for the other eye surgery, sir. For the traumatic eye SFIOL, we were planning it later only. That is why some patients are waiting for traumatic eye.
Thank you.
Yes, sir. Yes, sir. Thank you, sir.
So we have the last speaker, Dr. Ashish Margan. He'll be speaking on MIVS assisted SFIOL, tilt and decentration measurements using OCT, anterior segment OCT.
Yeah, a very good morning to all. So I'll be talking about 27 gauge MIVS assisted scleral fixation of intraocular lenses and AIOS2025-Free guided study. So we know that a number of sutured as well as sutureless techniques for SFL have been described, and amongst these sutureless methods have gained popularity as they bypass the risk of suture related complications. Techniques such as Jimenez has gained popularity in the recent times, and but it is associated with a long learning curve. Alternatively, a number of modifications have been described to the Jimenez technique, and we have also modified a technique using 27 gauge instruments, and we tried to study the IOL metrics using the AIOS2025 in the postoperative period in the patients who underwent this SFIL surgery, especially patients with traumatic dislocations or subluxations. So this was a retrospective study. All the relevant preoperative, intraoperative, and postoperative details were collected. Postoperatively, all the patients, they underwent AIOS2025 on Anterion at 1 month of follow-up to look at the following intraocular lens metrics, that is the IOL tilt, IOL decentration, and the distance of the IOL from the posterior iris surface. Exclusion criteria include the secondary glaucomas, the corneal opacities, previous retinal pathologies, and optic neuropathy. IOL tilt was defined as the angle between the corneal topographic axis and the central axis of the IOL. IOL decentration was defined as the distance between the fixation point on the corneal topographic axis and the central axis of the IOL in the cornea. and the distance of the IOL from the posterior iris was defined as the perpendicular distance between the posterior surface of the iris and the IOL at the pupillary margin. Postoperative details were collected. A pars pinna vitrectomy was done in all the cases associated with posterior lens or IOL dislocation or associated vitreous hemorrhage. An interior vitrectomy and a thorough port side vitrectomy was done in all the cases. Intraoperative surgical videos were reviewed to assess any complications encountered during the surgery. Necessary statistical analysis was done. Just a short video to show how the surgery is done. After securing the infusion, two 27 gauge trocar cannulas are inserted roughly at 1.5 millimeters along the horizontal meridian. So after this is done, now the intraocular lens is being injected, and using a 27 gauge max grip forceps, the leading haptic is being held and is extruded through the trocar cannula. The cannula is pushed onto the shaft of the forceps, and then using the heat cautery, the ends of the haptic are being flanged. A similar procedure is done on the other side. Once this is done, now the haptics are being tucked into the scleral tunnel, achieving a well-centered IOL. And the infusion is being taken out, so it is more of a sutureless, flapless, glueless technique for SFIL. So now coming on to the result, a total number of 36 patients were included with a mean age of about 34 years. Male to female ratio was 29:1. Indications were the traumatic dislocated or dropped IOLs, traumatic phacodonosis, subluxations, posterior lens dislocations, or previous surgical aphakias. The pre-op mean BCVA was 0.85, pre-op mean IOP was 16, and pre-op mean endothelial cell count was 2400. Postoperatively at 3 months, the mean BCVA improved significantly. The IOP as well as the endothelial count was more or less similar with no statistical significance achieved. Now coming on to the important measurements, that is the AIOS2025 measurements in the postoperative period, we found that the IOL tilt was 3.58, the IOL decentration was roughly 0.22 millimeters, and the posterior iris surface to IOL distance was 0.76. Now this is important because about 5 degrees of IOL tilt and about 0.2 to 0.3 millimeter decentrations is clinically tolerable to the patients. And the postoperative complications were that 4 patients, they had an IOL tilt requiring a repeat surgical intervention. 3 patients developed vitreous hemorrhage, which cleared on its own within a period of 1 month. And 2 patients developed choroidal detachment, which again resolved within a period of 2 weeks on oral steroids. Now, the mean refractive spherical equivalent was 1.14. That means all of our patients had a mean hyperopic shift. And when we tried to correlate them with the IOL parameters, we found that there was a positive correlation between the posterior IOL to the iris distance, whereas there was no correlation between the IOL tilt as well as the IOL decentration. These are the graphs for the correlation. So to conclude, 27 gauge MIVS technique for SFIL demonstrates a favorable outcome in terms of IOL tilt and decentration, contributing to improved visual acuity and reduced postoperative complications. Just looking at the review of literature, we found that the tilt in our cases was more or less comparable. Smaller is the gauge of sclerotomy, lesser is the tilt achieved, and the IOL decentration was significantly lesser to what has been achieved has been reported in the literature. Thank you. And just a heads up about the upcoming conference, the Comprehensive Cataract Conference in Delhi. Yeah. Thank you.
You don't need to mention that. You're not supposed to mention that. Sir, can you come to the mic?
What was your primary objective?
So we were
measurement of tilt or showing the newer technique of SFIL?
Primarily both, sir. So the technique has already been described once. There's just one paper on 27 gauge which came recently before we started doing this study.
Are you aware about AIOS lens design?
No, sir, I'm not aware.
You should. Which is already in the market.
And at the same time, when you are just putting cautery on the Prolene suture, mind you, Prolene is very strong suture, which actually need to hold the lens, but at the same time, if you cauterize, there can be sometime suture granuloma.
No, Prolene sutures were not used. This was the 3-piece IOL, and we did the cautery.
I'm talking about the Prolene suture, which you cauterize the end of the suture, right? Just to make it.
No, that was the tip of the haptic.
Haptic, okay. Haptic, polypropylene.
Yeah.
Okay.
Thank you very much.
I thank all speakers and participants, discussions for vibrant discussions. Thanks a lot. Thank you very much for joining us.
Can we have one picture with all the speakers, please? After that, we need to do some homework between our. एक picture ले लेते हैं. Shreya? Yes, sir. Right. Come out from the stage. Sir, you're the boss of trauma. Come up, come up, come up.
Sir, we feel so proud. I keep seeing you every day almost now.
So what we can do is we can stand there and students can stand on the stage. We stand up. Stand. All of you can stand here. We go behind us.
One second, one second. Sir, sir, इसमें लिखें sir. Thank you, sir.